Okay, so welcome everyone. You are on track 4 for this session on oral presentations on race and equity. We will have 3 presentations today. The first one will be by Simone Akyianu from the Legal Counsel at the Canadian Human Rights Commission. And the title of her talk is Race, Equity, and Housing as a Human Right. And then next we'll hear from Sally Arif, who's an Associate Professor of Pharmacy Practice at Midwestern University. Welcome, Sally. She'll speak to uncovering and mitigating our implicit biases to combat health inequities. And then we'll have Laura Botwinick, who's the director of the graduate program in health administration and policy at the University of Chicago. The title of her talk is Strategies for Dismantling Institutional Racism in Healthcare Organizations. So welcome all of you, and thank you presenters for coming and sharing about your work today. I'm going to go ahead and give the floor to Simone.
Thank you so much. So can everyone see the full screen?
We don't see your slides yet, Simone.
Not yet.
Not yet, okay.
And we welcome Simone, who's speaking from Canada today.
Okay. Well, thank you so much, everyone, for being here today. I'm really grateful to be in your presence, especially during these times. My name is Simone Akyianu. I'm legal counsel with the Canadian Human Rights Commission, and I do litigation as well as legal advisory work on housing policy issues at the intersection of systemic discrimination issues as well. Just a quick note that I'm just, the views that I'm going to be expressing today in this presentation are solely my own and not necessarily representing the views of the commission today. So yeah. So I'm just going to talk a little bit today about race, equity, and housing as a human right. So first, I'm going to just talk a little bit about race-conscious human rights approach, housing as a human right, as well as legal challenges, some of the ideological and social challenges in confronting, present approaches to the right to housing. And then, how do we really wrap those ideas up? And so I'm going to be taking a little bit more of a principled and a kind of higher level approach today to the discussion, but just hoping that that will start a conversation. And if any of you all have questions, please do let me know. And so when we're talking about a race-conscious human rights approach, I'm really drawing upon a rich tradition of scholars and activists, community-based organizers, including, for instance, Canadian critical race theorist Carol Aylward, who reminds us that race matters, and even in Canada, and that systemic racism and discrimination is often based on this notion of Canada as a white settler colony, which has impacted the land dispossession of First Nations and Indigenous peoples, as well as Black communities as historically enslaved communities. And so I really do draw a lot from that critical race theory tradition, as well as a substantive equality approach that kind of really tries to critically interrogate structural and systemic barriers to self and community actualization. If I'm borrowing the words of George Day, who's another critical race theorist in the Canadian context, an anti-racist theorist as well. And this often does also require interrogating settler mythologies that insist on, the innocence and the subtle dynamics of ongoing violations of fundamental human rights. And so part of that also just requires, critically examining processes of racialization and the law's role in creating and maintaining racial and social hierarchies, as well as deconstruction and counter storytelling, which are pillars of critical race theory as mechanisms for unearthing, pressing and emerging human rights issues, but also solutions to those. And so I'm going to talk a little bit about the Canadian context and, where we can kind of locate the right to housing in that context. So in Canada, we have the Canadian Charter of Human Rights and Freedoms. We have Section 7 of that charter, which guarantees the right to life, liberty, and security of the person. Section 15, which is the right to equality. We have a Section 15.2, which is like our kind of affirmative action / equity provision. And more recently, actually, we've had something passed called the National Housing Strategy Act in Canada at the national federal level. And this was passed in 2019, and this actually enshrines on a domestic basis the right to adequate housing. It also requires a national housing strategy and mechanisms such as public hearings on systemic housing issues and a federal housing advocate, which we are waiting for the appointment of. And so some of those mechanisms are housed at the commission as well, too, which will be interesting to see. I wanted to also just talk a little bit about the human rights litigation. And so when we talk about that, human rights litigation, when we're talking about that, one of the cases that I wanted to discuss a little bit is Tanujaja versus Canada. And so there's really a growing equality rights litigation on housing issues in Canada. And, this is often from women, Black, Indigenous, and racialized folks who are facing housing insecurity, have challenges, and who have actually sought relief from the government on the basis of failures to provide housing through the court system, essentially, though not always with success. And so Tanujaja versus Canada was a group of claimants, which included a young teenage mother, a father living with a disability, as well as another mother, and a nonprofit human rights-based advocacy group, which in terms of the individual applicants, they were all experiencing some forms of homelessness or housing insecurity, and they were able to bring a human rights challenge on the basis of violations to the Section 7 and 15 rights under the Charter. And so the applicants did argue that these violations stemmed from changes that were made by the government in relation to, removing rent controls, canceling affordable housing projects, downloading responsibility for housing to municipalities, for instance, without the appropriate and sufficient funding base. And so the provincial and federal governments kind of took the position that this was kind of drawing on a positive rights argument. They basically argued that, the charter doesn't really impose any positive obligations on the state to act. And the courts, they adopted that position. They accepted that and said, you know what, these are socioeconomic rights. This is not the place essentially for these kinds of contestations to be dealt with. And so they basically denied that claim. Black al versus City of Toronto is another more recent charter challenge, and that involved a group of applicants, including Derek Black, who self-identifies as someone who's Black, a gender diverse person of Indigenous ancestry, among other residents of tent encampments, who during the pandemic have essentially sought and went through the courts to try to get an injunction to prevent the city from dismantling encampments, and really trying to protect their rights under the charter again. And so that was another instance, and we're seeing a lot more of that litigation in the Canadian context, especially during the pandemic, which is really interesting. Sanctuary et al. Is another case as well too, where a number of community-based organizations, including the Legal Action Center, challenged the city's shelter standards in terms of whether it provided adequate social distancing in the wake of the COVID pandemic too. So I just wanted to give a few examples of important grassroots organizing that's kind of happening. And one mechanism in the Canadian context in which, folks and on the ground are really challenging and asserting the right to housing, and that this is really being done from the ground up and led by folks with lived experiences of housing issues. And so it's worth noting that actually there's some case law as well, coming out of the British Columbia context in Canada, where courts have actually recognized Section 7 rights of homeless persons. And they've actually successfully argued, for instance, that city bylaws pose, threats to health and security of the person, which are protected under Section 7, in the context of not having adequate shelter spaces and not being able to accommodate people facing homelessness. And so there's some really interesting litigation coming out in the Canadian context as well on some of that. I wanted to talk a little bit also about some of the statistics and kind of housing issues that are happening. So we have in Canada, 1 in 10 families are living in core housing needs. This means essentially they're facing issues of affordability, suitability, and adequacy. So they're living in overcrowded housing conditions, housing in need of repairs, and racialized groups or people of color, essentially vis-a-vis white peers, are twice as likely to be in core housing need, to fall into that category. So that's something to keep in mind. The affordability crisis is one in Canada also that often disproportionately impacts women, often at the intersection of gender and family status. And so those are just a couple different pieces to keep in mind as well. And certain groups also are, as I mentioned, are disproportionately impacted. So we have Black communities are, 19%, although only making up 3 or less percent of the national population, and First Nations and Inuit and Métis communities as well too, highly overrepresented, as well as recent refugees and newcomers and immigrants as well too, overrepresented in terms of statistics with respect to experiencing core housing need. So one of the more recent issues that I also wanted to draw attention to is the issue of forced evictions. And so that's been something in the city of Toronto, actually. We've had recent studies from Scott Leon and James Evaniuk from the Wellesley Institute releasing reports and actually having some interesting findings around, poverty playing a significant role in evictions, which is nothing new in terms of that finding, but seeing that there's census tracts with 53% of renters in poverty having 2.5 times higher eviction filing rates, as well as disproportionate impacts on Black communities as well too. So looking at the intersection of anti-Black racism and forced evictions too. And so all of that is important just to kind of see, what does it mean really when we're talking about the right to housing, right? I think it's one of those things where we really need to start taking and kind of fleshing out a more principled approach for understanding what the right to housing is, and really understanding that, it centers around it being necessary for human dignity, as well as sense of belongingness, community connectedness, our well-being, self and group actualization, and some of those pieces. So I just wanted to make reference to a few different international sources of law. So we have, for instance, the International Covenant on Economic and Social and Cultural Rights. So Article 11 of that convention essentially allows and recognizes the right to housing as an integral part of having an adequate standard of living. So that's one piece where one area where we can find that that right to housing pronounced there, as well as the International Convention on the Elimination of All Forms of Discrimination under Article 5, and the Convention on the Elimination of All Forms of Discrimination against Women under Article 14. So the right to housing is and there are a number of other sources as well too where that's recognized. And so that's an interesting piece. And so I think one of the important pieces as well is to really define what we're really getting into when we're talking about that. So some of that includes, as recognized under international law and under the general comments to the International Covenant on Economic and Social Rights, includes recognizing that housing has to be provided and everyone's entitled to that, right? Like without discrimination. It requires legal security of tenure. So in the example that I talked about earlier in terms of forced evictions are actually considered a prima facie violation of the right to housing under international law. We also have, as part of the right to adequate housing, the need for the availability of services such as access to water, affordability. So that's one of the larger issues that happens in the Canadian context, which requires essentially from that guideline and principle, housing costs to be in line with income levels, and really not being able to, shouldn't surpass 30% of a person or a household's income. Habitability is another component of the right to housing as well too. So that's just thinking about adequate space, overcrowding, freedom from environmental toxins and hazards. Accessibility is another piece as well too. So ensuring the entitlement to housing is available for persons who are living with disabilities, as well as elderly communities as well too. Location, so the importance of having it close to and near childcare centers, employment, food security, that notion. And then lastly, cultural adequacy, which really ties into housing, the importance of housing being available in a way that allows for people's full expression of their cultural and racial identities, and providing diverse forms of housing as well too. So social housing, public housing, a range of different housing that can really meet everybody's needs. So I'm just gonna talk a little bit about some of the persistent theoretical and practical challenges when we're talking about the right to housing. And one of that, we really start to think about, historically, there's really been a devaluation of the socioeconomic rights doctrine, as evidenced even in the Tanujaja decision that I mentioned earlier, right? So the courts really relied on this distinction between socioeconomic rights versus civil and political rights. And that distinction is often made in evidence by the actual separation of the International Covenant on Civil and Political Rights versus the International Covenant on Economic, Social, and Cultural Rights. And so that has often given fodder to courts to say, oh, this is not something that this socioeconomic rights, such as the right to housing, is something that's like a lesser order or a second order of a human right, but really we know it's not, right? And so positive rights essentially are often conceived and understood as requiring specific measures for state intervention, and for the states to really ensure that role to implement and to make sure that that's happening for folks. And so that distinction and not being able to invest in those socioeconomic rights, it really has material consequences for especially Black, Indigenous groups and women, and gender diverse peoples. And that often effectively excludes them from the housing market, right? So this is against the backdrop also of the increasing commodification and privatization of housing, which we have had reports from the UN Special Rapporteur on Housing, including the former one, Leilani Farah, in terms of really developing that concept and understanding why are we seeing the devaluation of housing, and framing that as a commodity versus as a social good and a fundamental human right. And so those are some of the kinds of background, I guess, practical and theoretical challenges behind some of that. I think it's also really important when we're talking about a principled approach to implementing the right to housing to really also think about what are the historic and contemporary realities of social disadvantage that are shouldered by certain communities, right? So in the Canadian context, we have historically, even in Canada, although the mythology around it is not the same around it in terms of the US context, is really one of anti-Black slavery, settler colonialism, the displacement of certain communities, including in Africville, Nova Scotia. And so those different pieces are really important to take into consideration. We also know systemic racial discrimination is something that's been captured a lot in certain studies in the Canadian context in terms of the social science literature, in terms of that being a barrier to housing for many groups in the private rental and ownership market as well too. And lastly, just kind of thinking about this against the backdrop of legal liberalism, right? And thinking about that, the insistence on incremental approaches and incremental steps towards implementing the right to housing. And so often there's government retreat from intervention in the housing market, and a very laissez-faire approach to housing to keep in mind. So in terms of just wrapping that up and kind of wanting to come together a little bit, I think it's really important to kind of flesh out a little bit of, what's the vision for meaningfully being able to implement housing as a human right. And so I've just put a few different pieces to just kind of think about it. One of them is, really, again, taking this principled and normative approach to housing as a human right that's centered around dignity, self and group actualization, addressing housing as a social determinant of health, really at the intersection of race, class, gender, and sexuality. So there's a number of social science literature in the Canadian context as well too, which talks in depth about housing as a social determinant of health, and so the importance of that for our well-being. The third piece I would add to that is being able to assess facially neutral policies for their remedial or adverse impact on historically disadvantaged communities, right? So, when we're thinking about mortgage loan policies and other kinds of policies that are seemingly neutral, what are their impacts on communities who have experienced historical and systemic forms of discrimination? And so really being able to do a methodical and kind of contextual assessment of those even seemingly neutral policies. Lastly, fostering meaningful opportunities and equitable outcomes for grassroots organizations and communities to really come together and shape and build housing outcomes. And I just underlined equitable outcomes because I think we often talk about this equality of opportunity. And of course, we know substantive equality approach, especially the one recognized in Canadian context, is one that really tries to turn its mind to remedying inequitable outcomes and really shifting the discussion to that lens. And then lastly, really thinking about how do we implement proactive housing policies that really redresses historic disadvantage. And so, for instance, in the city of Toronto, they recently have a housing charter, which is kind of like an action plan around implementing the right to housing. And they have also recognized at the municipal level the right to housing. And one of their goal points there is to ensure that a specific percentage of affordable housing that's now developed is set aside for women and girls. And so that's one example of a human rights-based outcome to be able to really put forward from a proactive equity-seeking lens, right? How do you secure and meaningfully implement that right to housing? Another example is in our municipal in our planning act in the Ontario context, in our provinces, for instance, some of the provisions, including Section 34 of our planning act, incorporates provisions to be able to implement inclusionary zoning policies, for instance, where cities have the ability to impose and include community benefit charges on new developments to be able to set different targets that would include housing for specific groups of people and for for specific purposes, such as affordable housing. And so that's really some of the kinds of policies we really want to start to see in terms of really being able to meaningfully implement that right to housing. And so, yeah, I'll just leave it at that for now. And thank you so much for listening.
Thanks, Simone. That was great. If no one has any objections, I'd like for us to hold questions until the end, until all the presenters have presented. So please hold your questions, or if you want to type your questions in the chat box so the presenters can take a look at them. But we're going to hand it over now to Sally Arif. Sally?
Thank you so much, Maria. And thank you to everyone that's joined us today for this session. We're going to switch gears a little bit, and we're going to start talking about something that usually makes people kind of uncomfortable and a little defensive, to be honest with you, which is uncovering and mitigating some of our implicit biases as we think about the first steps when it comes to combating health inequities that eventually usually arise from implicit bias. I am a pharmacy professor. I teach in this space. I've been doing this for several years. I've run lots of workshops and around implicit bias and cultural competency or sensitivity building for students, in addition to my practice as a clinical pharmacist at Rush University Medical Center. And I'm currently chairing the American Association of Colleges of Pharmacy Health Disparities and Cultural Competency SIG. My learning objectives are hopefully by the end of our short time together, you'll be able to describe, if you haven't learned, how implicit biases are formed, identify the impact of these biases potentially on interactions with patients as healthcare professionals or those that work on teams, and list some strategies that you can actually start using to reduce implicit bias that might be presenting itself when we're trying to practice culturally sensitive care. Before we dive in, I'm going to ask everyone if you are wearing a watch or a ring or a bracelet or anything on your hand or wrist to switch it over to the other side. So the side you usually don't wear it on. Now, this is a weird request, but I promise we'll come back to this at the end of my talk. So kind of to reiterate, I think the years I've been doing talks on implicit bias and researching it, whenever I do approach an audience, I think some of the first statements I hear, and usually it's rumblings in the audience, is this really doesn't apply to me. I have friends and family from all walks of life. I've dedicated myself to, as many of the attendees of this conference, to serving the underserved, working with the others that I know many others don't, do. I've dedicated myself to being fair. And while all these statements are true, and I don't defy them with a talk like this, that doesn't necessarily mean the same thing as what we're talking about when we say implicit bias. So I think we have to kind of start at the definition of what exactly is a bias. And this is, thinking about prejudiced beliefs or attitudes in generality towards a particular group based off a shared identity, whatever that identity might be. Explicitly, I think we're more aware, right? When people might explicitly have or harbor bias, they might shield it because of political or social correctiveness, but they know and they're aware of that bias. What we're talking about today is more implicit biases, the things that are kind of seated in our unconscious or subconscious. We are often not aware of them. They are rooted in unsupported assumptions about every type of identity you can think about when it comes to race, ethnicities, sexual orientation, gender, and the list goes on. And what's interesting about implicit biases is they often don't align with our expressed feelings, beliefs, values, worldviews, and such that we are aware of. So that's what makes them so tricky. So you can think of implicit biases as kind of the stories, the narratives that we make up about people before we actually ever really uncover who they are. And so as healthcare professionals, we're interacting with patients day in, day out, people from all walks of life, even in our everyday life, right? In our social lives, with our family members, with people in our communities, How does this play out with those narratives that we might be relying on when they might be, again, rooted in assumptions that are not true? Why does this kind of happen? So if you think about the brain, we're taking in millions of pieces of information through our senses every minute, but we're consciously only really allowed to become aware of a fraction of those and able to, in our efforts to try to function in every day. So what we do is we rely on these mental shortcuts and we make meaning. That's what we're hardwired to do. We make meaning and narrative around what we're seeing, what we're experiencing, what we're perceiving. And then we tend to categorize things, oftentimes as in-group or out-group. So we think about racial biases, implicit biases, those tend to, again, reside in the unconscious network, and they can stack up quite rapidly. And biased messages from our environments can be framed to speak to that unconscious. If we really kind of break this down, I want to give you an example before we move into strategies or why this happens even further. If you look at the screen right now, you should be seeing just two arbitrary shapes. Hopefully these shapes mean nothing to you. But if I asked you to name one boba and one kiki, which one would you name which? I bet you many of you did this. And I don't read minds, and this is not an experiment I came up with. This is one that was first introduced in 1929 by Dr. Kohler, a German-American psychologist, who looked at the fact that the human brain is designed to make meaning out of the most arbitrary things. So we're not even looking at faces here. We're looking at two shapes, and we're taking sound, and we're applying a name to those arbitrary shapes based off the sounds that we hear and the shapes that we see. This study, the Boba Kiki effect, has been replicated around the world across many cultures and many languages. And over 90% of participants do the same thing. They label the left object as Boba and the right object as Kiki. Why does this kind of happen? We think about the fast thinking and the slow thinking parts of our brains. We have these two systems that are always at play. System one is really that fast thinking process where we take in information very quickly and we usually base it off of past context, things that we've learned. Our amygdala is really responsible for system one thinking, for mounting a strong response, and usually that's kind of that fight, flight, or freeze response. It keeps us safe often, but it also may lead to false, again, response or behavior due to, again, basing it off of past context or mislearned information. System two, which is housed in our prefrontal cortex, is our slow thinking, our center of logic, our rational thinking, where we take in objective information and we try to be objective with our response to it. Unfortunately, the system one thinking is 100 times faster than system two thinking. So before you know it, when someone presents themselves to you, like this individual here, pre-pandemic, of course, not masked, but if this individual is handing over a drink that you ordered, are you going to mount a defensive response? Are you going to feel angry? Probably not, right? Because there's a learned response of smile in many cultures means friendly. This person is providing a service to you, and you'll happily take the drink without even thinking about it. But if you're walking down a dark alley and you see this individual on the right-hand side coming at you, before you can even think about things like, I wonder if this person's having a bad day. I wonder where he might have gotten this knife and what he plans to do with it, or what his profession is, or if he has a family, what his lived experience has been like. You're probably already using system one to run the other way. Again, like many animals that have system one and system two thinking, we're doing this usually to be protective of ourselves. Unfortunately, this can misfire when we're thinking about interactions on a quick basis, often with our patients. So this diagnosis bias, or the propensity where we label people, ideas, and things based off that initial opinion of them, can get us into situations in which we contribute then to health inequities. Every day we're interacting with lots of individuals that come from various backgrounds, and we think about intersectionality and we think about the different identities that everyone has. We can think about the fact that we're primed often to make some of these implicit biases come to the surface without even realizing it. I hope at this point I've just gotten you curious enough that you're wondering, how much does this apply to me? So if you haven't heard about the implicit bias test from Harvard, which is a free online resource that over 2.5 million individuals around the world have taken, I hope that you'll take some time after this session and look into it. Take one of these tests. They've got them on race, religion, age, weight, disability, and the list goes on. And what this test does is it actually allows you to see your preference, your assumptions about individuals from particular groups. This is an exercise I do with my students, and I have them reflect on it, intentionally reflect on their results without sharing them necessarily with the group. If you're also an educator like me, other resources that you might want to steer people towards that you might be training are the Ohio State Mitigating Implicit Bias in Healthcare website. The Kirwan Institute also has a lot of great research. And then Race Equity Tools, which is a website that has a lot of exercises and activities also that can be used in the classroom or on clinical site experiences. And again, if you're a healthcare professional like me, it's sometimes hard to believe this when we've taken an oath to be fair to our patients, to be fair and equitable in everything we do. But the research shows otherwise. The research shows that healthcare professionals are just as primed, just as likely to make these implicit biases come to the surface when they're practicing in whatever setting they might be in as the general population. When we look at studies about how patients that might be African American or Black agree that race affects their health, much higher rates than white patients. And when we think about surveys that have been done with the public, patients versus healthcare professionals like physicians, we see often again a skew in where the problem might lie, where healthcare professionals often think that they are being fair when it comes to looking at someone's race or ethnic background, for example, in the way that they make decisions in their treatment plans. So the consequences in bias in healthcare are vast. We know that studies have shown also under treatment of prevalent disease states like pain, cardiovascular disease, diabetes, HIV, etc., that negative interactions with patients arise, mistrust of providers by patients, which obviously we know leads to worse outcomes in their health. And really, where we see this most often is in disadvantaged, marginalized populations, where unequal care, and that's what eventually leads to the health inequities, are really the most detrimental part of all of this. So I don't want you to make you feel like, oh, well, I have implicit biases, I'm human, that means I'm automatically prejudiced. No, it doesn't. It just means you're human, that we all have that fast thinking brain that is going to mount some responses. The goal here is to kind of become aware of how this might play out, that biases are going to potentially influence our perception and the reality around us in our places of work and the people we interact with, our attitudes towards certain people, the behaviors that we have, so how receptive or friendly we might be, the attention we actually give, how much time are we dedicating to particular patients or groups, how actively are we truly listening without distraction to certain groups, and even empathy, how much empathy we're showing or comfort we're showing to particular patients or groups. How did we get here though? How do we develop these over our lifetimes, especially when we've dedicated ourselves to being fair? You can think of implicit biases as kind of a slow fog that's been happening throughout our lives. As we have come in contact with media images, news images, the conversations even around dinner tables that we've been at over our lives, the education systems, the parts of the country that we've lived in, the people that we've interacted with, that slowly these kind of assumptions and associations have formed over time. And so as much as you might have learned that peanut butter and jelly go together, you might have also, unfortunately, learned that a Black male goes with violence or crime. And although we might explicitly have values that don't believe in that, we might implicitly have that in the background. So Harvard professor Chris Hargis kind of put this in this reference of the ladder of inference and how we take data, observable, objective data, and we tend to quickly add meaning to it, that cultural, personal history that we have. We make assumptions from this. We draw conclusions. We adopt belief systems. And then we actually take action. And this reflexive loop happens over and over again. So the next time we see someone that might elicit a response that looks like someone else, we're going to automatically go up this ladder of inference. So the goal is that we stop ourselves at the lower rungs of this. We catch ourselves before we get up to the belief systems and the actions and really check ourselves on this. We don't lead to conclusions or snap judgments based off of someone's education and whether they're going to make the right medical choices. We don't look at someone who might be late to their appointments and assume that they don't care about their health. And we think about the cultural context of time, for example, or that certain patients are going to be non-adherent with their treatment plans because, again, of learned associations we've had with previous patients from a particular group. And we are, again, primed to make mental shortcuts at certain points. I don't know about you, but I would say this list applies to almost every minute of my day. I feel like my time is limited. I feel like we've got a lot of emotions going on in our world right now. We've got to act now, be present, multitask, and be hyper-focused on many of our tasks. When we're in these situations, what the literature shows is that we, again, rely on our fast-thinking minds more often than our center of logic. Because, again, we have to get stuff done. And so we're going to go up that ladder of inference much faster and allow for some of these implicit biases to surface in different ways. The solution to all of this is not about being blind, right? And saying that we don't see color and we don't see age and we don't see all of these different identity points for individuals. What the literature actually shows is ignoring biases actually furthers inequities. That if we deny that this is happening to each one of us, then we actually contribute to the problem. And that it's nearly impossible, if you think about it, to be objective and neutral in everything you do, because we all hold values and beliefs, we all hold worldviews, we all hold traditions, we all hold these things that shape who we are. So these biases are present, but what we require is this constant monitoring, that we really focus in on it when we think about our disadvantaged, marginalized groups especially. And we think about making it a point with every clinical encounter we have with our patients to approach it, to look at that person as an individual and to audit our thoughts around that individual and not what background they might come from. So the good news, like we've said, to recap, is everyone has implicit biases, but they don't align with our values explicitly. They are pervasive, but they are malleable. And although we may have learned them over time, they can be unlearned. So I wanted to spend kind of the last few minutes talking about strategies. How do we do this? How do we maybe practice some unbiasing techniques? And the two keys to this is really being mindful, first of all, present in our thoughts about our own racial anxieties and bias. Really doing that inner work and really calling it out with ourselves. And then secondly, really being authentically committed to changing this within ourselves. So I'm going to talk about 4 strategies that have come up quite a bit in the literature. The first one is perspective taking. And this says these are not earth-shattering concepts, but it's really, I think, powerful to kind of think about it and maybe try to make a vow that you'll try to do some of these things in your everyday encounters, practicing them from day to day. Take 1 or 2 even. So perspective taking is really that idea of putting yourself in the other person's shoe, which is the essence of empathy, right? To walk in that person's shoes, to treat that person as they would want to be treated, not how you would want to be treated or how you think they want to be treated. So listening in, really getting their history, understanding what their life goals are, what their medical goals are, if you're on a treatment team for them, and what their apprehensions are, what their barriers are, and really understand that perspective. The other strategy is engaging with others. And I think this was put so well by Michelle Obama in her recent autobiography, Becoming, where she said, it's very hard to hate up close. And I know this is scary for many folks where you're seeking out people that belong to groups unlike yourselves, because oftentimes we are very much drawn to individuals that are familiar to us. But I think seeking out others, and this might be challenging in the state of COVID with social distancing and not necessarily being as integrated into groups. But even if you thought about social media, what's populating your feeds? It's usually like-minded people, right? And so you kind of get to see the algorithm of other people that think the same way you do, that see the world the way you do. What if you started following individuals that had different viewpoints than you? Following individuals that might actually be individuals that you don't really know a lot about, that might come from groups that you don't know a lot about. That could start to just in itself start deprogramming some of the assumptions that have been harbored again in your unconscious. The third strategy is stereotype replacement. So the idea here is recognizing at the moment, taking a pause before we have a response and thinking about how much of my response might be rooted subconsciously in a stereotype for that particular group, and then adjusting your response, thinking about the opposite of your response, or thinking about the opposite of what you think that stereotype would be for that particular group. And what helps with stereotype replacement is looking again at individuals as individuals, seeing people as individuals rather than part of a group that might be stereotyped. There's been studies even in emergency departments where they've actually taken social histories of patients who identify as homeless before they talk about what their complaints are or their symptoms are. By asking patients about human things like, what is your favorite food? What are your favorite pastimes? What have you been up to? What are your goals? What are your dreams? And you start to see that you can relate to that human to human, that I also like tacos, that I also like beach vacations, that I also have kids. That tends to make you shift to that slower thinking mindset, that system two, that place of logic, rather than jumping into the routine of going through an intake, for example, the same way you always have, or you routinely will kind of prime yourself to think back to some of those assumptions. So these biases you can think of as habits, and habits take time to break. So the first thing we need to do is acknowledge, first of all, that we harbor them. So getting out of that denial, motivating ourselves to change, paying attention, being mindful when stereotypical responses or assumptions are activated, taking time to dedicate to debiasing strategies so that we break these automatic associations, and that this is going to be a slow and methodical process, that it's really first about becoming aware, but that it's going to feel a little uncomfortable. So I want to go back to that feeling that maybe some of you have had if you practice this little exercise we had at the beginning of switching to the other finger or wrist. You probably came to and from your attention to that ring or watch or bracelet that you might be wearing because it feels unnatural. It's not quite completely uncomfortable, hopefully, but it's there. And so you're auditing it every once in a while. And that's kind of the feeling that I want you to capture when we think about some of these debiasing strategies, that it's not supposed to feel completely uncomfortable all the time or excruciating, but that you're always kind of coming back to it until you can start to break some of those associations. So disrupting these implicit biases is always routinely asking yourself, what biases do I have? Getting out of the denial, embracing discomfort, because in discomfort we grow. That realizing this is not about perfection. This is really about connection. This is about enhancing our ability to build rapport and advocating for the patients that we really are externally dedicated to serving. So with that, I just kind of wanted to recap our takeaways, that no one is immune to having implicit biases. We're all hopefully becoming more aware of them. Getting uncomfortable before we become comfortable is key to this process. And that unbiasing techniques and strategies can be practiced so we can promote connectiveness with our patients and hopefully decrease some of the inequities that result if we don't pay attention to this. So that I want to thank everyone for your attention today. And I guess we'll wait till the end to take some questions. Thank you.
Yes, thanks, Sally. Thank you very much for your presentation. We'll now turn it over to Laura Botwinick.
Does that look okay to you on the screen?
Looks great.
Okay, thank you so much. Thanks to my other panelists for those great presentations. My presentation is called Dismantling Institutional Racism in Healthcare Organizations. We're talking about health equity, and we're in the middle of a pandemic. So I wanted to start with these statistics. We're all painfully aware of the impact, the unjust impact this is taking on people of color. And the stats from October 13th is that 108.4 deaths per 100,000 Black Americans, 90 deaths per 100,000 of Indigenous Americans, compared to 54.4 deaths per 100,000 for white Americans. This is from the APM Research Lab website, and they're updating these statistics. And they also add that, that if these populations had died of COVID-19 at the same rate as white Americans, 21,800 Black people would be alive, 11,400 Latino people, 750 Indigenous, and 65 Pacific Islander Americans would still be alive. So we're in the pandemic. We have gone through an incredible period of protest and kind of awakening on the part of many people who hadn't formerly been quite aware of the level of systemic racism in our society. The previous image was from Minneapolis, and these are some images from here in Chicago, taken from the Sun-Times and other media outlets. Everyone was moved. So many of us went out and marched. And many public statements were made in support of Black Lives Matter. Corporations, nonprofit leaders, including many healthcare CEOs and university presidents, everyone put their statements of solidarity up on their websites and committed to addressing systemic racism, in their organizations. And so this work that I'm going to share with you is to give people a roadmap, to give hospital CEOs kind of a roadmap on how they can address institutional racism in healthcare. It comes from work that the Institute for Healthcare Improvement did, and it's their Achieving Health Equity initiative. I was a fellow at the Institute for Healthcare Improvement about 15 years ago now, and I've stayed in touch with them as a member of the alumni network. And I have been working on issues around health equity and was invited to participate in writing this white paper, which really had huge uptake. It was published in 2016. It was downloaded by hospitals all across the country, and it contains a framework, which I'll share briefly. And then an organization started to work on this. I'm going to come back to this slide about institutional racism. This is the framework that was in that white paper. And it has these 5 parts. Make health equity a strategic priority. Develop structures and processes to support equity work. And that includes having dedicated staff, creating the ability to track data and stratify it by race and ethnicity. A huge one is to deploy specific strategies to address the social determinants of health. And that's saying that hospitals need to get outside the walls of just focusing on clinical care and connecting with others to provide housing, education, access to social services. And then the 4th one was eliminating institutional racism within the organization. and really looking at the structures and processes that cause disparity. And the last one is to develop partnerships with the community to achieve all of these. Then IHI embarked on something called the Pursuing Equity Initiative. And there were 8 leading organizations, including Rush University Medical Center, that participated in Pursuing Equity. And they began to implement this framework. And the one that I'm going to focus on now for the rest of this talk is the third one of eliminating institutional racism. I'm going to go back to this slide where Kamara Jones defines institutional racism. It's structural, having been codified in our institutions of custom, practice, and law, so there need not be an identifiable perpetrator. So what are those structures and processes and norms that are causing disparities and inequity? Those laws and policies and norms have been developed over the entire history of the United States, starting from the time of slavery, where laws were in effect to justify and support slavery, then to Jim Crow era, where segregation and discrimination and horrible inequity was codified in the law, to today, where we're still building on those laws. And we need to understand how that's impacting our organizations today. I was really moved by reading the new Jim Crow, which, many years ago I read that, and she describes how structural racism is, what the mechanisms are in the criminal justice system. So then we want to ask, what are those mechanisms inside healthcare organizations? Now, inside healthcare organizations, healthcare organizations are responsible for about 20% of health, and everything else are all the other factors. And so, as Kamara Jones will say, healthcare organizations aren't going to solve this problem on their own. We have to address all of these issues. It's all about structural racism. But let's just focus on healthcare organizations and see what those mechanisms are that we can dismantle. This slide talks about the history of documenting inequities in healthcare. Here's many of those inequities listed in bullet points. We still have them today. These are the Pursuing Equity organizations that were the original 8, including Rush, as I mentioned. And there's David Ansel from Rush University Medical Center, who really was a leader in that Pursuing Equity initiative and continues to be. And many of the lessons from the work in that white paper and the further work come from him and from Rush's work. There's that framework. And here's what it looks like today, where IHI has kind of made it more of a circle that is circular. These are my main colleagues in the development of that other work and this coming work that I'm going to tell you about. Ron Wyatt, Amy Reed, and Dr. John Whittington. This is the breakout of that one framework relating to institutional racism and other forms of oppression. And this is kind of what, if CEOs wanted to focus on dismantling institutional racism, the things that they should focus on. I'm going to do a time check here. Okay. So the first is, and I've broken this out into several slides so that you can see it better. Understanding history is so important. Healthcare organizations need to understand the history of the United States, the history of the city in which they're located and the community, and the history of the organization itself. They need to understand the communities of color that they're serving or could be serving, should be serving. And this learning the history, reckoning with the history, can help people in the organization and leaders understand their own privilege and the benefits that they've achieved from a racist. Another thing that we put under understanding history is the important issue of building trust with patients, partners, and the community. And when there's so many things around trust and health and disparities, but one thing I could say is understanding also what harms the healthcare organization might have caused to the community, that the community still carries with it and that keeps them outside the walls of the institution. The next one is everything around culture and communication. So it's really important to normalize conversations about racism. And this is something that Dr. Ansel talks about so often and did during the initiative. And that really has been an important part of changing culture and communications within the organization. Have discussions with people so their voices are heard. Change visual displays in the organization. Maybe we shouldn't have all those pictures of the white board members who've served ever since the beginning of the organization on the walls in all the hallways. It should be comforting and welcoming. Question norms that play within the culture of the organization, hairstyles, attire, and ways that people define professional. Question dominant narratives. Recognize the important role of leaders in setting the anti-racist tone and priorities. We say, if something happens in the community or something around like the George Floyd killings, something that an anti-racist leader can do is demonstrate the solidarity with the forces of anti-racism. Deeply listening to patients, partners in the community is also part of this element. Within human resources, we say address equity in hiring, promotions and pay, diversity in leadership, focus on that, focus on having demographic parity with the community. And if your medical school and other health professional schools, focus on bringing in diverse student bodies. Human resources has to do with widening your networks and pipelines for candidates. And we learned things in this research, like if you want to have a person of color in a position, you need to have at least 2 people of color on the short list as you're narrowing this down. Business practices is another category. And we said, diversity, inclusion, and equity must involve changing systems, education and training, revise policies and procedures so that you're conducting racial impact assessments as part of policy development, part of your decision-making. Consider equity when you decide where to locate facilities and what insurance to accept. Invest in the community. Think about procurement practices, local hiring. And some organizations are using organization funds in the investment portfolio to participate in community investment and housing. There's an initiative called the Anchor Mission Strategy, and I know Rush is participating in that. There's over 40 organizations now across the country in an Anchor Mission collaborative that's looking at really investing in the community to reduce the wealth gaps. And finally, clinical operations, which is looking at measuring disparities and consciously reducing gaps in clinical disparities. So the work on that kind of driver diagram, that framework that I just shared with you, has been documented in a new guide that was published in December 2019, and it's free on the IHI website. There's also a write-up of the 2-year Pursuing Equity initiative, where all the teams report out on their experience. And there's a new initiative right now going on that they call Pursuing Equity 2.0, where there are about 25 organizations that are doing a deep dive on that framework and building on the work of the first 8 Pursuing Equity organizations. So with that, I want to close just by saying that this work is so important. I know everyone here is working on this, these issues, and I look forward to us all having a better world and making a better world together.
Thank you so much, Laura. So this, we have time for questions and discussions. I want to open it up, and feel free to either go ahead and ask a question, or you can type up your question in the chat. And while you're all picking up your questions, there's just a couple questions that have come to my mind as you're speaking. And you know, the three of you have touched on sort of this idea of how do we engage an equity perspective, and how does it intersect with human rights, how we are as human beings in our role, and with our biases, and contributing to and engaging that perspective of human rights, as well as, you know, how do we engage in a racial equity lens. So I think one of my questions is for the three of you, how at this juncture, in the midst of pandemic, in the midst of a racial unrest, in the midst of an election time in our country, and it'd be interesting to hear your perspective, Simone, from Canada. You know, how do we think about equity on the ground, and how do we make sort of structural competency, structural justice tangible in the day-to-day, in our day-to-day work, whether it's in a public health arena, in a pharmacy practice, you know, in a legal practice. What is it that we really need to consider on a day-to-day level? How do we integrate these perspectives in our day-to-day work?
Thank you so much for that question. One of the things I'll say is I feel like there's a rich tradition of organizing and you know, community-based work, and I think it's always important to also turn to those who are most affected by the issue in question to really help them. To really have them lead the conversation, have them lead the policy, have them, and really doing that in a way that's not just tokenistic and performative, which sometimes, and especially in this context, sometimes it can go in that direction. But really making space, whether it's, you know, creating committees, paid committees for people to actually provide their input, and then see that input developed into a policy, a tangible policy, you know, whether it's in a law firm or a legal practice or any other kind of setting too, right? There's an opportunity, I think, to work with some of the communities who are most affected by it and really letting them lead it as much as possible. So I would say it starts there. And then again, just having a lens for what the historical patterns are and how sometimes, you know, there are very subtle forms of violations of human rights. There's very subtle forms of exclusion or a tokenistic kind of gestures. So as much as possible, just really making it a meaningful opportunity and outcome for folks to be involved if that space is being created.
Mm-hmm.
I would agree with Simone. I think as I think about just leading some student groups who are so motivated and the intentions are so great to get out and serve, even in these times, I think some of the principles we always have to keep in mind is that we have to check ourselves on a savioristic attitude and really pull up chairs, like Simone said, for community engagement in whatever policy procedure, whatever space we're intending to work in, and that we listen before we speak, that we really do our homework to understand what are the violations from their lens, where is it that they need assistance, need support, need resources before we make those assumptions ourselves through our lens alone. So I think those are some of the principles I think about. And then the other part of your question about like, what can an everyday person do? I think you have to think and reflect about your own personal capacity. And I struggle with this too with my students who are, just ready to go out there and make change happen tomorrow, yesterday. And it's, pausing for a second, and we don't want to add more harm. And we really need to reflect on our intentions first and do it in a meaningful way that's going to be sustainable. So those are some of the things I think, looking at, your capacity as an individual and where do your strengths lie? Where can you contribute? And sometimes it's just small change, it's kind of reining back a little and saying, we don't have to go out there and change entire systems. And that's usually those things fall apart when you think about structural change overnight. It's making meaningful small change. And where is your place in that? Where can you leverage your strengths to help with some of the initiatives that are already happening around you?
My response to your question about how do we make these actions tangible made me think about what healthcare organizations are doing who are on this journey to, when they stratify the results of their care by race and ethnicity, when they see those graphs and they see the disparity, that starts to make it real. And then when they start to work on trying to improve the gap and find it hard, maybe they're like inside the organization, they're brainstorming, what can we do? What can we do? Nothing changes. But when they finally do connect with the community and find out what the issues are for them around the care that's being provided, then they begin to make progress on reducing the disparities. So that's one way when you're really looking at the data and seeing the change.
Thank you. What other questions do you all have?
I have a question for Laura. Good to be with you. Good to see you.
Hi, Wes. Good to see you.
Thanks so much to all of you for your presentations. And Laura, I was really interested in the issues you raised about the paper, which I read a long time ago. It's been a while since I've read that paper, but the question I have is about labor and internal pay issues within hospitals and healthcare systems, which do as a pattern mimic or show racism and sexism and class inequity in terms of how workers are paid up and down the hierarchy within our health systems. There's a really good AJPH paper I have in front of me right now that notes a lot of these inequities, and I'm not going to list off a bunch of them. I'm just curious, are there any health systems that are doing this really well, that have responded to this inequity in a way that's really positive? I'm also really mindful about CEO pay being just really off the charts disgusting high in a lot of instances. and that does relate to the way that other people are compensated within health institutions. So, I had this question come to me earlier this morning when I was talking with someone about this issue, and I didn't know of any institution that had been doing it really well, but I'd love to know if you've come across any in your work.
There's one of the 8 pursuing equity organizations is called Vidant Health, and they made a commitment pretty early on to pay a living wage to everyone. So they raised the minimum wage for the lowest paid employees, and it made a huge impact on their lives and building trust with the community and retention and all of that. And so they were able to even document the benefits in terms of retention and of course just how it felt to be in that organization. And then to further that, there were a couple, I think Mainline Health and a couple of the other organizations, and now several around the country, but I can't name them. But they are looking. There's an MIT. It's some sort of guide that is able to tell the living wage amount in cities all across the country. And so organizations that are working on this issue are encouraged to find out what that wage is and pay that wage at least, and so there are organizations working on that. And then, even documentation about the benefit of doing that. I can send you it was actually a webinar of some organizations talking about that initiative. And let's see what else I can think of. I mean, even Rush University Medical Center, David Ansel would say that one of the things that they did was to stratify they would look at all their own employees and see who was actually taking advantage of the benefits that were available, like tuition benefits and even retirement plans. And they would stratify by race and ethnicity and learn, that the lowest wage employees, and often people of color were not able to take advantage of those benefits. And so they said, how can we change our policies internally to make a difference there? And one example that he describes is for the tuition benefit, they realized, hey, our policy was that people would have to put the $5,000 up front before they could take the class. And they said, well, we're just not going to do that. We're going to pay for it and they can take the class. And another example along these lines came from Vidant Health. And that was that they had required a certificate for some of the low wage employees to work in some of the lower wage jobs, certification. And they realized that really wasn't essential to do the job, and that they could bring in people from the community, get them, working in the organization with a commitment to get the certification, that the organization could pay for. So those kinds of things people are starting to work on.
Thank you very much.
Laura, can I ask you a question as well? So
Sure.
From your work and expertise, kind of thinking back to that historical perspective that needs to kind of be the foundation to this work. And I'm even coming at this not just from healthcare institutions, but even higher education institutions that are usually predominantly white, coming from a place of privilege. How do you start changing kind of that culture? Do you have examples of success stories and how you can kind of get people there, or how institutions have been able to get individuals there? And unfortunately, what you highlighted was prior to May, sometimes it was like screaming into the void. And now, unfortunately, but fortunately, there's focus. But there's this fear, the momentum slows down, and how do you get genuine onboarding of and culture change when it comes to striving towards prioritizing health equity?
Yeah, it can happen a number of ways. Oh, thanks, Wesley's putting the paper in the chat so we can go take a look. Before I answer that, Wesley, I thought of another example of what organizations are doing, and that is around eliminating it's the ban the box initiative, so that people are no longer requiring that people, declare if they've been in prison. And another example is to not set somebody's salary based on the salary that they had been earning, because that just perpetuates the race gap. So there's a move to do that. It also helps the disparities between pay of men and women. So just don't ask and don't base a salary on what somebody was previously making. So let's see, the question about how to start the journey. We've seen it happen a lot of ways. One way is to do a survey, around disparities and people's understanding of health equity, and then you can just show the results and how so many people don't believe that it exists. You've shown a gap within your own organization that you can begin to work on. That helps buy-in, for the need to work on it. But you can, I sometimes think about it like we think about patient safety too, and medical errors. Like if some horrible medical error happens and somebody is, killed in the facility due to a medical error, that's a significant, sentinel event, and the organization rallies around the need to improve safety systems. Similarly, errors and inadequate care can be analyzed from issues around, was implicit bias involved? What was institutional racism involved? So you can get people to begin to understand the need for change if you analyze poor care from that perspective.
Any other questions?
I have a question for, did you have
Go
another
ahead, Laura. No, go ahead.
I had a question for Simone. When you started talking, you talked about how the laws, that racism is embedded in housing law. And that kind of gets to my, my constant curiosity about how do we see that, and I think you may have presented it, but can you think of a certain, an example of the law that was, perpetuating systemic racism in housing?
Yeah, that's a great question. I think I kind of tangentially raised it in terms of talking about facially neutral policies. And so just as an example, so in the provincial rental housing context, that's covered in our system under provincial laws, under provincial human rights laws, essentially. And there are practices often that landlords sometimes engage in, and it might be just, asking for source of income, for instance, or doing a ratio to income test, asking for Canadian references only, so all of these kind of on their face, they seem very neutral, they can be applied to anybody, but certain people might have an adverse impact when they're applied to certain groups of people because of course, historical disadvantage and that kind of thing, and the intersection of poverty in when we're thinking about housing too. So that's one example. So some of these discriminatory essentially screening practices, right, that effectively exclude many communities, and especially Black and Indigenous and other racialized communities out of the rental or other housing market. And so I use those as examples because sometimes I think we are still hanging a little hard onto the intentional aspects of, discrimination. And I think it's really important to shift that narrative and start really assessing the discriminatory effects and impacts of laws that where, as you've said in your quote as well too, where there's no identifiable perpetrator.
Yeah, great, thank you.
Any other questions? Any questions or comments? Okay, I want to thank Simone and Sally and Laura for presenting your work. Today, I know I learned a great deal. I just took some notes. We did record this session, and it will be available on the Center for Community Health Equity website, hopefully soon. So I appreciate your time. I want to thank all the attendees for coming, and want to remind you that there's another keynote session at 3:50 with Kim Wasserman from the environmental organization at Little Village. They hold, and she'll be talking about environmental justice work at 3:50. But I hope you all have a good afternoon and a good weekend. It was good to see you all on the session today.
Thank you.